Sayeedur Rahman Khan. I welcome you all to my presentation. This is a case-based discussion on IVUS. My first case, Lieutenant PCI, a 6 years female hypertensive, presented with class 3 angina. Echo shows anteroseptal hypokinesia. E was 45%. And angiogram shows Lieutenant Australis the 80 to 90% stenosis, midhand 70 to 60 to 70% lesion. LCX was normal but non-dominant, and RCR proximal has 30 to 40% lesion. The question was, this distal left pen was involved and it was significant or not, and mid LED was functionally significant or not. First, we pre-dilate the ostium of the left pen with 2.5 to 8 mm NC balloon. Then do the PCI IVUS. It shows MLA of the left pen less than 6. It is plaque burden more than 70%, and left pen diameter about 4 mm. We do the PPCI if you are in the LED mid part. It shows it was a functionally significant lesion. So we do the PCI from the ostial left pen to LED with the 3.5 into 38 mm days and 3 into 24 mm days overlapping both stand, and post dilate with 4.5 into 12 mm NC apex balloon at high pressure. And post stenting IVUS shows image of the left pen ostium and left pen mid and distal is not satisfied. And this is the final result. According to ACC AHA guideline, IVUS use class 2 recommendation during assess the severity of unprotected left pen lesion, complex coronary artery stenting, and assess the mechanism of the stent failure. My second case, an 40 years female dyslipidemic, old anteroseptal, echo showed anteroseptal hypokinesia with EF 45%. Angiogram finding was distal left pen has 20 to 30% stenosis, LED osteoproximal has 90% stenosis, LCS osteoproximal has 70 to 80% stenosis, and RC was normal. According to Medina classification and definition criteria, it was a true left pen to bifurcation lesion and complex lesion, and angle was less than 70%. So we planned for IVUS guided decay crash. We pre-dilate both lesions with E4 2.5 into 10 balloon. And pre-staining IVUS in the LED show ML of the left LED ostium only 3.4, and ML of the L6 ostium 3.4. So first we stenting done in the L6 with ortho 3 into 22 mm balloon, then cross the side branch and rewinding the side branch. Then perform the first case with 3.5 into 10 NC balloon in the LED and 3 into 10 mm balloon in the LCX. They do the stenting from the left pen to LED with resolute onyx 3.5 to 20 mm stent, and then first spot done with the NC for 4.2 to 8 mm, and rewinding side branch done, and second case done with the same balloon, and second pot done 4.5 into 8 mm NC balloon. Post stenting IVUS in the LED show image of the LED ostium 11.94 and good stent expansion apposition on the SD section. But in the LCX ostium, the MSA of the LCX ostium is 4.8. So we took another NC 3.510 balloon and post dilate the ostium again. So we had to do the third case again and third pot again. And this is the final IVUS in the LCX. Now MSA in the LCX ostium is 7.86. And this is the final result. My another case, 52 years male, diabetic, presented with CCS class 3 angina, had PCI to LED with DST into 28 mm, 6 months back. His echo was normal, and CAG finding left pen was normal, LCX stenosis 20 to 30%, and the mid part RC was normal, but there is something in the left LED proximal. There is a diffuse ISR in the proximal to mid part of the LED. We wired the lesion with the help of microcatheter and filter XT and Hollister PTC wire. Then pre-dilate with Genos 1.5 into 10 mm balloon. Then do the IVUS. Then IVUS shows previous stent was well expanded, but there is the ISR at proximal stent age, proximal mid and distal stent, and MLE was significantly reduced and minimal MLE was 1.62 in the proximal LED. So we pre-dilate sequential pre-dilate the lesion with NC quantum apex 2.75 into 12 balloon, then 3 into 8 mm balloon, and this is the final CAG after the pre-dilatation. And IVUS of pre-dilation showing now MLA of the lesion is improved. So we do the stenting from with Promus Premier 3.5 into 20 mm balloon from the LED osteoproximal from the proximal part, And the distal part, we do the DCB with 3.5 into 20 millimeter balloon. And post dilate with NC mosaic 4 into 8 millimeter at high pressure. And final IVUS show good stent expansion apposition, no dissection. And MSc in the LED ostium, proximal, mid, and distal part was satisfactory. And this is the final angiographic result. IVUS may help determine extended mechanism of stenosis for optimal treatment strategy, also location and amount of thrombus. Case 4, journey with blind eye. A 75 years female, hypertensive, diabetic with CKD, presented with CCS class 3 angina. ECO was normal, but serum creatinine was 1.8 milligram and EGFR was 29 ml per minute. CAG findings, left was normal, but LAG proximal to mid part 90 to 95% stenosis, which was calcified lesion. LCS proximal part has 40 to 50% stenosis, and RCA mid part has 50 to 60% stenosis. We plan for an IVUS guided ultra low contrast PCI. We engage the guide catheter without contrast injection, build the metallic shield of the heart with the guide wire, then do the IVUS in the LED. There is a significant reduction of the LED in the LED proximal, mid, and distal part, and there is more than 180 calcium arc with the mid LED. We do the calcium score, but the score was only 1. So pre-dilated lesion in the NC 2.5 into 50 millimeter balloon, but there is a dog bone effect. And IVUS after pre-dilation showed very few crack. It was not satisfactory, so we took Wolverine cutting balloon 2.25 into 10 and pre-dilate the lesion again. And IVUS after cutting balloon showed multiple cracks in the calcium arc. And we do the stent sizing with the help of the IVUS. LED distal landing zone diameter was 3 millimeter and proximal landing zone diameter 3.6 millimeter. And proximal landing zone is 4 millimeter distal to LDLC bifurcation, and distance between proximal to distal landing zone was 35 millimeter. So we took 2.75 into 38 millimeter stent, and stenting done in the proximal to mid LED with Giants Alpine 2.75 into 38 millimeter 1080 patient. And post dilate with NC 3 into 15 millimeter balloon. And I was after stenting showing malapposition of the stent in the proximal part. So post dilate with NC quantum apex 3.5 into 12 millimeter the LED proximal part. And final I was showing good stent expansion apposition and good MLD in the proximal mid and distal LED. And this is the final angiographic view. IVUS in ultra low contrast PCI provide landmark for lesion identification, provide information on stent apposition and expansion, better patient and procedural outcome, least chance of AKI following procedure. My last case, PCI complication. A 52 years male, diabetic, class 3 angina, echo was normal. Left vein was normal, LED proximal part had 95% stenosis, LCS distal part has 80 to 90% stenosis, OM was 100% stenosis, and RC proximal has 90% stenosis. We pre-dilate with Wilma 2x15 balloon, then stenting done with expedition 3 into 20 millimeter days. Post-dilate with stent balloon at high pressure, and this is the final result. But during the final angio shot, there is something in the proximal of the left vein dissection of thrombus and slow flow and no flow. Quick warding of the LED and 6 done. IVUS LED to LM showed hematoma in the left vein dissection flap in the LED ostium, hematoma proximal LED. So rapidly stenting done with the osteoproximal left vein to proximal LED with Giants expedition 3.5 into 22 millimeter days. Post dilate port done with the mosaic 4.5 into 10 balloon. And IVUS after stenting, no dissection, hematoma dissection flap in the LED, and this is the final result. Take home message: IVUS is no longer a luxury but an essential tool for the daily practice in the cath lab. But unfortunately, image guided PCI only possible in 12 PCI center in Bangladesh. Thank you for patient hearings.
You did the left main with mid LED lesion, predilate the left main, then you do the FFR to the mid LED. So why FFR you do the mid left main? Why not the IVUS in the same setting?
We also did the IVUS.
So what was the IVUS finding in the
IVUS is borderline.
So after doing the when the left main lesion is there, mid LED FFR, how much it will give you opinion? So there is left main lesion, mid LED there is lesion, FFR in the mid LED, is it reliable?
No, it's an yes crosstalk between proximal and distal region. So therefore, we try to measure if you use an FFR, if the pressure, we have to pay attention to the bigger pressure gradient region first. We have to treat that region first, and then measure again and decide whether we have to treat or not, right?
Or else non-hyperemic.
Non-hyperemic, yes, pressure ratio is much better. We can speculate.
You can take a non-hyperemic.
Yeah, just pull back,
Pull back.
and you can
Step up.
speculate the step up portion. If you treat there, you try to yes shift to the same position, and you can speculate the final result, right?
Sir, if we just do the IVUS only here,
Yeah, there are some IVUS criteria, but physiology is much better to identify the ischemia, right? Yeah.
But physiology is losing its sign over trials.
Yeah.
One trial
Yeah,
positive, one trial negative.
I think yes, there are advantage and disadvantage, and yeah, we are very yes, people are very like to discuss which is better, but both are complementary method, right? So, but the medical source is limited. That is a problem, right?
Rumi, what is the cause of your ISR?
ISR.
ISR. And whether you can use the DCB in both the definitions rather than the one proximal stand and distal DCB.
We didn't show the pre-dilatation CAG. After pre-dilatations, the proximal LED that was not stated before recoiled. But in the ISR part, when we pre-dilate, there is no recoiling. So we'll plan for DCB in that segment, and proximal though that recoiled, so we plan for another test there. There was a functional cause. Stent was well expanded, no stent fracture.
Sir, I have one question, both of you. In left main bifurcation stenting, left main LED LCX, what about the technique? IVUS or OCT, do you prefer routinely pull back from LED to left main and LCX to left main?
Yes.
Both way.
You want to comment about the ISR? What was the cause? There happened.
ISR, ISR always you may not get a cause. It's sometimes mechanical, it may not be. It could be a tissue hyper responsive to the
Yeah, so if you find that there is no stand under expansion problem, then it's always going to be intimal hyperplasia being the cause of it. Yeah.
biological process.
So thank you so
Thank you,
much, all the experts, panels, and speakers. Thank you all, and audience. And it is a lunch.